Dear students, the topic which I am going to deal today is on the contributing factors for cardiovascular diseases. To begin with, cardiovascular disease is a term that outlines a range of conditions affecting the heart and blood vessels. The first alarm of an underlying disease is a heart attack and stroke. The majority of cardiovascular diseases occur as a result of risk factors that can be controlled, treated or managed, such as cholesterol, hypertension, malnutrition causing overweight and obesity, tobacco usage, physical inactivity and diabetes mellitus. From this module, you will be able to understand the concept of cardiovascular disease and its contributing factors in detail. Now let's see the WHO specifications on cardiovascular diseases. The World Health Organization specifies cardiovascular diseases as a group of disorders that include coronary heart disease, cerebrovascular disease, peripheral arterial disease, rheumatic heart disease, rheumatic fever, congenital heart disease, deep vein thrombosis and pulmonary embolism and atherosclerosis. Moving on to the categorization of risk factors. The risk factors are broadly classified into two as modifiable and non-modifiable risk factors. Based on the categorization given by American College of Cardiology, the risk factors are divided into four: three modifiable and one non-modifiable category of risk factor based on the intensity of the condition. The risk factors includes category 1, smoking and tobacco usage, LDL cholesterol, hypertension, left ventricular hypertrophy, thrombogenic factors. Category 2 includes diabetes mellitus, physical inactivity, HDL-C, cholesterol, obesity and menopausal status. The third category involves psychological factors, triglycerides, lipoproteins, homocysteine, oxidative stress and alcoholic consumption. Whereas the fourth category includes age, gender and family history. Let's move on to the next factor, the low density lipoprotein cholesterol. Low density lipoprotein is involved in the development of coronary heart disease and various other conditions. The risk of cardiovascular disease can be decreased by the decrease in the level of LDL cholesterol in the body. It is evident that a decrease of 1 milligram of LDL cholesterol results in a decrease of 1 to 2% in the risk of cardiovascular disease. Aging, genetics, dietary habits, postmenopausal women with reduced estrogen levels, high blood glucose, hypothyroidism, nephritic syndrome, obstructive liver disease, obesity and drugs including steroids and antihypertensives are the major factors increasing the LDL cholesterol levels. The diet rich in saturated fat and cholesterol increases the LDL level cholesterol by suppressing the LDL receptors by the liver. With the decreased activity of the liver receptors, LDL clearance from plasma is slow and the result is high plasma levels. The mortality, morbidity and progression of atherogenesis can be decreased by lowering the LDL cholesterol level. Including monounsaturated fatty acids and PUFA, soluble fibers, etc. and weight reduction lowers the LDL cholesterol levels. The next risk factor in category 1 is hypertension. Hypertension is not a disease but a symptom for an underlying health condition that is progressing. Hypertension disrupts the pumping function of the heart, causing vascular injuries and stresses the myocardium and, if untreated, damages the heart, brain and kidneys. It may also result in stroke. The prevalence increases with increase in age. Hypertension is an indicator for conditions like hypercholesterolemia and obesity and also the presence of metabolic syndrome. Lowering the blood pressure and maintaining a normal levels decrease the incidence of cardiovascular disease. Moving on to left ventricular hypertrophy. High blood pressure and increased workload secondary to obesity causes an increase in the size of the left ventricle. This is a risk factor reported in all age, gender and ethnic groups. Next is the thrombogenic factors. The intracoronary thrombosis causes most of the myocardial infarctions. Plasma fibrinogen is an independent predictor of coronary heart disease risk. The causes for increased fibrinogen are smoking, sedentary lifestyle, elevated triglycerides and genetic factors. 30 to 50% of the fibrinogen level variations are genetic. Moving on to the next factor, the dietary factors. Saturated fatty acids tend to elevate blood cholesterol in all lipoprotein fractions when substituted for carbohydrate or other fatty acids. The most hypercholesterolemic and atherogenic saturated fatty acids are lauric, myrcetic and palmitic acids. For every 1% in total energy intake from saturated fatty acids, a 2.7% increase in plasma cholesterol is predicted. A 1% increase in omega-6 PUFA would lower total cholesterol by 1.4 milligram per deciliter. If carbohydrates are replaced by linolenic acid, the predominant dietary omega-6 polyunsaturated fatty acids, the LDL cholesterol is lowered and the HDL cholesterol is increased. Stereoisomers, that is the transforms of the naturally occurring cis-linolenic acids, are produced in the hydrogenation process and are widely used in the food industries for hardening of unsaturated oils and soft margarines. Increased intake of these trans fat increases the level of LDL cholesterol and lowers the HDL cholesterol level. Hope you are clear with the category 1 risk factors pertaining to cardiovascular disease. Now let's move on to category 2. Diabetes is not only a disease but also a risk factor that may lead to cardiovascular disease. Both type 1 and type 2 diabetes mellitus increase the risk of coronary heart disease in early ages. The major mortality caused in people with diabetes is due to atherosclerosis. The next is physical inactivity. The physical inactivity or low level of fitness is an independent risk factor of coronary heart disease. It is mostly related to sedentary lifestyle where the risk factor is 2 times more when compared to active people. The magnitude of risk is similar to that of high blood cholesterol or smoking. Even with awareness, the physical activity is reported low and is common in elder ages. It is the most prevalent modifiable risk factor of cardiovascular disease. Regular physical activity and mild to moderate exercise suffice to maintain a normal lifestyle. The increased physical activity decreases the incidence of coronary heart disease by retarding atherogenesis, increasing the vascularity of the myocardium. Increasing fibrinolysis and modifying other factors such as increasing HDL cholesterol, improving glucose tolerance and insulin sensitivity, aiding in weight management and reducing hypertension. The next risk factor is high density lipoprotein cholesterol. HDL performs various functions like the process of reverse cholesterol transport that helps rid the body of cholesterol by transporting excess cholesterol from membranes to triglyceride-rich lipoproteins which are removed by liver receptors. This prevents the accumulation of lipids in the arterial walls. Low HDL cholesterol has reported to increase the risk of coronary artery stenosis. The simultaneous decrease of LDL cholesterol and HDL cholesterol has been reported to decrease the risk of coronary heart disease in middle age to 34%. 1 milligram increase in HDL decreases the coronary heart disease risk by 2 to 3%. The normal HDL level is considered at 60 milligram per deciliter, and level below 40 milligram per deciliter is considered to be a risk factor. The obesity, tobacco usage and smoking, physical inactivity, androgenic and related steroids, etc., the genetic factors and postmenopausal states decrease the HDL cholesterol levels, whereas the exogenous estrogen, exercise, loss of excess body fat and moderate consumption of alcohol suggests an increase in the level of HDL cholesterol. The next risk factor being obesity. The BMI of an individual is directly proportional to coronary heart disease. As BMI goes up, it increases the risk of cardiovascular disease. A 1 kg increase in weight increases the risk of diabetes by 9%. Obesity affects atherogenesis by various other underlying factors, especially glucose intolerance, diabetes mellitus, hypertension, dyslipidemia and increased fibrinogen. The triglyceride levels 35 to 48 milligram per deciliter is higher than average, indicates a direct relation to higher BMI, especially in women. The level of risk depends even on the distribution of weight in the body, mainly the upper body or abdominal versus lower body distribution. This also affects the glucose tolerance and serum lipid profiles. Then is the menopausal status. Natural or surgical menopause is associated with lower levels of estrogen. This is because estrogen protects from vascular injury, thereby reducing the risk of cardiovascular disease. During the menopausal period, there is an increase in total cholesterol. LDL cholesterol and HDL cholesterol levels and decreases the HDL cholesterol level, especially in those who gain weight during that period. There is an average of 19% increase in serum cholesterol level in women undergoing menopause. The next is the category 3 risk factor, which includes the first one, psychological factors. Psychological factors like impatient, compulsive time, urgent personality with high stress, social isolation, depression and illiteracy are all indirectly a risk factor for cardiovascular diseases. The second one being triglycerides. Hypertriglyceridemia is a common metabolic syndrome that is recognized as a risk factor for coronary heart disease. The serum level of triglycerides are inversely proportional to the level of HDL cholesterol. Factors that increase the level of triglycerides include diet, estrogen, alcohol consumption, obesity, untreated diabetes mellitus, hypothyroidism, chronic renal disease and liver disease. Weight loss, consumption of low saturated fat, low cholesterol diet, decreased refined carbohydrate and increased physical activity, smoking cessation, management of diabetes, restricted alcohol use, all these factors helps in reduction of triglyceride levels. Next is lipoprotein A. Lipoprotein A has a character similar to that of plasminogen, a proenzyme which is involved in the breakdown of fibrin because it has ApoB in addition to ApoA. It is an independent indicator of premature coronary heart disease. Homocysteine is the another contributing factor. Children with low cystathione B synthetase, the important catabolic enzyme for homocysteine, has proved to cause premature atherosclerosis. Hence, homocysteine is proposed as a risk factor for cardiovascular disease. Hyperhomocysteinemia is associated with occlusive vascular disease in the coronary, cerebral and peripheral arteries. It modifies the apolipoprotein and makes it unavailable to LDL receptors, and it also causes vasodilation. Homocysteine activates procoagulants and inhibits anticoagulants. Genetic factors such as a variant in methylene tetrahydrofolate reductase or inadequate dietary intake of folate, riboflavin, zinc and vitamin B12 and B6 increases homocysteine level. The next contributing factor is oxidative stress. The process of oxidation of LDL in the vessel walls speed up the atherogenic process by stimulating macrophages, stimulating autoantibodies and increasing the uptake of LDL and thereby increasing the vascular tone and coagulability. The next factor is the alcohol consumption. Limited alcohol consumption is proved to be beneficial to the heart, but alcohol abuse with excessive consumption increases the risk of coronary heart disease and increases the blood pressure. Finally, moving on to the last category, the category 4, age. The age factor comes under the non-modifiable risk factors of cardiovascular diseases. With an increasing in age, there is a gradual increase in the risk of heart damage, and this is peak at the age of 50 to 55 years. The next is the gender. The premature disease in men 35 to 44 years of age is 3 times higher when compared to women of the same age. In women, the risk is higher after the age of 55 years, which is mostly after menopause. Next is the family history. A family history of premature disease is a high risk factor for cardiovascular disease. An individual with family history of heart disease are likely to get an earlier stage in men before 55 years and women before 65 years. The family history is a factor that may lead to atherosclerosis, as there are about 30 genes involved in the process, such as apolipoprotein E, a fatty protein molecule that help in removal of cholesterol from the body. It is genetic to have increased fatty streaks and plaque. So people with combination of risk factors are at higher risk of developing coronary heart disease. To summarize, the cardiovascular disease includes group of disorders in blood vessels and heart. The risk factors of cardiovascular disease are classified as modifiable and non-modifiable. Students, hope you all clear with the risk factors pertaining to cardiovascular diseases. Thank you for listening. Let us see in the next session.